now, right?
Okay, and I'm
Perfect.
just going to quick swing my door so that there's less background noise.
Thank you, guys. So just for the
So
purpose
Merritt,
of recording, we should probably say why we're here. Maybe Alexandra, would you mind?
yeah. So we're here today to give an update on the incredible work of ALS and Alzheimer's research taking place here at Massachusetts General Hospital. So Run to Revive has been supporting Mass General Neurology since 2017. And, this is the latest happening in 2022 and 2023. So I'll kick it off to Merritt because I know it's been a hot year for ALS.
Thank you. First of all, thank you for the support. It's enormously helpful and it allows us to speed up the research and take bigger risks and to really try to cure this illness. I'd say that 2022 and now 2023 have been like no other year in ALS. It really gives me hope that we're gonna figure this illness out. So why do I say that? So 2 new drugs approved by the FDA. One oral Adaravel and the other one Relyvrio. We were very involved in the Relyvrio, which is by Amylyx, and they one of them slows the illness by 1/3, the other one about 27%. They both extend life, and so improve function in life. And then we have a 3rd drug under review right now by the FDA, March 22nd, an AdCom, which is the first gene therapy for one of the genetic forms, which, for me, because I've been involved in it since it started and I see patients, some of my patients are in it. This is the first time in 30 years I've seen a drug actually stop the progression in some people, and some people get better. It's extraordinary. And it tells us that if you can figure out the most proximal cause of the illness and a way to block that or change that, you can actually stop this illness. And that was something that was kind of theoretical before, but now we've actually seen it with that first gene therapy. That gives me like enormous hope. And I'll say the other thing that gives me enormous hope is when I go to science meetings now, there's thousands of people and a lot of young people and just new brains coming into the field, and the progress in understanding the biology for the sporadic form of it, the more common of it, is just outstanding. So it's exciting. I have more to share, but maybe I'll stop there for the high level overview, and we get to hear from Brad about Alzheimer's disease.
All right. Well, I'm also want to just add my thanks to you guys. This kind of support really does make a difference to us. It gives us an opportunity to really try some things that are higher risk, and to support programs and to support people who, are making a difference. And similarly in Alzheimer's disease, it's what Merritt say, it's been a year like no other, right? So 2 drugs approved by the FDA, both neither cure the disease, but both slow the rate of progression. And that's the first time, really, again, in 30 years that I've seen data that's really convincing that we're impacting the disease. For many years, people thought, oh, you've already lost all those neurons. The brain's been so damaged, like game's over. And game's not over. We're able to make a difference. And this is something that it's funny to hear Merritt talk, because theoretically we had argued for years that game shouldn't be over. There's this possibility, but it was all sort of academic, theoretical. Data are data. It's really exciting. Having said that, it's not without controversy how much of a change there is. And man, I want to make people better. Slowing rate of progression is not, that's great. That's fantastic. That is literally better than nothing. But better is what we all want. And I've seen the data too from the gene therapy trial that Merritt alluded to, and we're starting some gene therapy trials in Alzheimer's disease as well. And in both in the data in patients in ALS and the data in experimental models in Alzheimer's disease, it looks like better is possible. And it's incredibly exciting. And as Merritt said, we at MGH have been at the center of these gene therapy trials, going back 10, 15 years when it was just sort of a glimmer in the, gee, is that even possible? Kind of eye. And now it's turning into commercial products that are going to see patients.
It's so exciting to hear these sort of developments. And I know last year when we spoke, both of you got excited about like 3 areas about how these progress, right? The sort of the pipeline of drugs to slow and halt the progression in both diseases, the technologies to repair and function, and then the prevention, sort of delay in onset. It seems like those 3 areas have accelerated in all facets, correct? And I mean, I want to, Dr. Hyman, you said something that maybe some of the treatments, the gene therapies may be sort of controversial. Could you share a little bit more about, how you guys are pushing those barriers a little bit, and, where that excitement is coming from? Because this sounds amazing updates.
So part of it is on a technicality of how the FDA has operated in the context of the Alzheimer drugs. So there are, broadly speaking, 2 paths towards getting a drug approved by the FDA. The sort of standard one that's used the vast majority of the time, which is that a process is shown to be safe, relatively speaking, and effective. So it has to both not hurt you and also help you in order for the FDA to approve it. And that help you is a very pragmatic, are people better, right? Have they actually improved? And with the 2 Alzheimer drugs that have been approved were approved not on that basis, but on the basis of a less used pathway that the FDA can use. And that pathway doesn't seem likely that if people took this drug for long enough, it would do them good.
Okay.
And that's based on something called biomarkers. So a good example of that is in cancer therapy, where if you have a cancer therapy and you take an X-ray and somebody has a tumor that's this big, and after the treatment, the tumor is only this big, like everybody goes, well, that's good. That's made things better. And even if you haven't shown in the course of your 6-month trial that people lived longer or that they, whatever, the FDA will say, well, gee, smaller tumor, that's a good thing. Let's take it on faith that a smaller tumor will ultimately do people well, and let's get it to patients, and not wait for the however many years it would take to really demonstrate the length of survival, outcomes. And similarly, in these 2 Alzheimer drugs, they're using a biomarker, in this case, an X-ray of the brain that sees the amyloid plaques. And both of these drugs do an amazing job of getting rid of the plaques. They absolutely, unequivocally get rid of the plaques. And the trial was only 18 months long, and whether or not people had a clinical improvement and how big that clinical improvement was, still, statisticians can argue, and statisticians always argue, fine. But it's unequivocal that the plaques are gone. When I started in this field, everybody thought that plaques were made of concrete and could never be removed. In fact, one of my close colleagues, one of his early contributions was proving that plaques couldn't even be dissolved when you isolated them and you put them in water and you ground them up, and you couldn't get rid of them no matter what you did, unless you added a very, very, very strong acid, and then they would finally dissolve, right? So these things are tough to get rid of. The belief was that they would never be gotten rid of. And now we have 2 drugs that get rid of them, and more on the way that'll do the same thing. So, but it's the controversy comes from, all right, you've gotten rid of plaques. That's great. What good does it do? And that's not proven yet. And the emphasis there is on yet. Just not enough time has gone by. But there's, in everything, people who are a little more conservative and go, well, let's wait to see whether or not, it really works the way you think it's going to. And other people who go, we have patients who need this now. Let's just go for it, and we will learn as time goes on. It's not like we're gonna go like this. We're gonna learn as time goes on how this helps, and that's where that I think that's my interpretation, at least, of where the debate is.
Yeah, there's a push because these people that have these diagnoses are desperate, right? And then there's resistance to approve the drugs because they're not fully proven and fleshed out. But to your point, maybe we just need more time, and we need people testing these drugs in clinical trials and then expanding them beyond the limited use that they have now.
And it's sort of a judgment call. I sure do understand that the FDA has a responsibility, and a legal responsibility, to make sure that stuff is safe and to make sure that it actually does what it says it's going to do. I mean, these are not cheap drugs, and they're not going to be, they're going to be difficult to give. They're going to be difficult to monitor. There's side effects to them. I mean, I do understand that the FDA has this responsibility to, make sure that some thought goes into it. And I think it's a legitimate question right now. How much good will they do? And, we just have to find out. And we're doing that in the laboratory, and we're doing that with people. And, we're going to do our best to move this forward as fast as possible. Because like Merritt, I see patients, and, they want something now.
I know
they're right.
Merritt, in the field of ALS, biomarkers are being used a lot more frequently, right, to speed up sort of early diagnosis and to start maybe treatments earlier. Can you speak a little bit about, because that seems like an exciting new area of treatment as well?
Yeah, so so the huge area, both fluid and digital type biomarkers for earlier diagnosis and for intervention. So the best one we have so far is something called neurofilament light chain, which is some protein that's normally in your axons and your neurons. And in ALS and in some other illnesses, it leaks out, and you can measure it in the blood and the spinal fluid. And for example, the gene therapy I mentioned that's under FDA review, after 12 weeks of treatment, it lowered that marker, neurofilament, 50%, which is huge. No other drug has done that. And it actually lowered, we detected that before we detected the clinical signal, which took longer. It took about 6 months to start to see the clinical effect of slowing, 8 months until we started to see people not progressing, and about 10 months before we saw them start to get better. But the neurofilament changed at 12 weeks. So that I say it's like Brad's comparison of a tumor. That in a way is our surrogate marker, our initial shrinkage. So every study now is including neurofilament. And, we just reported out the results of our platform trial, and one of our drugs had a 40% lowering of neurofilament. So we're very excited about that. But this idea of a platform trial actually started in Alzheimer's, and we brought it to ALS. And it's the idea of testing many drugs in the same infrastructure and sharing the infrastructure, sharing the placebo data, and really speeding up how you determine if drugs work or not. And so we launched the first ALS platform trial called the Healy ALS platform trial in 2020. We have results of the first 4 drugs. Like normally in that time period, you get 1 result. So we got 4.
You were lucky.
Yeah.
2
of them were negative, clear negative, but that's also important. And with good biomarkers to show that they hit their target, and and they're not worth what going forward. But the other 2 were positive on several markers, including neurofilament, and they're going to go forward to phase 3 testing. And we have 3 other drugs now who have entered that platform trial. So, and the exciting thing is there's so many areas in neurology that want to take this kind of way to speed up therapy development. So we've talked to at least 12 different groups, and from Parkinson's to traumatic brain injury and stroke, who who finally have enough drugs in the pipeline that it makes sense to use this platform trial approach.
It's amazing. Is this a result, or are you seeing the benefits of the ALS Act that was signed in 2021? The hope was to help fund sort of on a larger scale. And you guys have always been like the masters of collaboration, but that seems to now be having a ripple effect to other areas of neuroscience. Are you seeing now the benefits of that?
Yeah, so the ALS Act was an amazing $100 million a year for ALS, mainly for compassionate use studies. So to help people who might not be eligible for the trials, which might have more rigid inclusion criteria, to help them get access to the same medications, and also to learn like the biomarkers in that maybe a slower population. So we actually applied for the first round of that, and we actually got the first ALS Act grant for a compassionate use study with a company, Celos, which is one of the companies we're working with on the platform trial. And we're working hard now. The next call came out. We're putting in four applications. So I think it's phenomenal. And also, the NIH is just finished a strategy plan for ALS of that we were part of, and many people were part of, to help them on how to use some of these funds and to hopefully get more funds. Congrats. So it's phenomenal. This is a great bill.
Yeah.
One of the things you guys have alluded to is the costs of some of these drugs. And I think, the ALS drugs that are showing promise are costing something like $150,000 a year. So what do you see as like how that evolves, and how much more accessible those drugs become to the masses that need them but can't afford them?
Yeah, this is a big challenge. I'd say, like, last year my advocacy was to convince the FDA that they should approve a drug on a single study and not require 2 studies like they do in cancer. This year's advocacy is around not just the price of drugs, but also insurance companies paying for them. So I mentioned these 2 new drugs that came on the market. They're each about $160,000 a year. For both of them, the companies, like 100%, the insurance companies say no on the first prescription. If we appeal it, and on average it takes 3 appeals, we will get it funded for 90% of people. It consumes an enormous amount of time of our staff, but the patients, and like, what's the point of having 2 drugs approved if we can't get them for people? So it's a big problem on both ends. Like, what's the right price point, but also, why are insurance companies not paying for drugs that the FDA and the community thinks are important? So so there's a whole ALS community that really works together. It's an amazing community we're all writing with the patients and the doctors and the nurses, writing editorials and papers about this, because it's a huge problem, but it's much bigger than an ALS, but we're living through it right now. Brad, I'm sure it's Alzheimer's.
Yeah, no, you can just echo exactly that the Alzheimer's Association has put exactly that point as their major advocacy point for 2023. And it's, if the drug is approved and the FDA has done a thoughtful job of deciding whether or not this is warranted, then we should make it available. And with Alzheimer's disease, especially, that has a more federal flavor to it, because many people have their health insurance, via the federal government rather than through private insurance when they're in their 70s and 80s. And so but it's going to take legislative solution and a ground roots effort, and really just a societal belief that this is worth doing, that we have to take care of people.
I know we've only got a few minutes left. So, I think on our last call, we wrapped up with talking about preventative measures and, risk factors, and how, the message of Run to Revive and how it sort of correlates with what you guys are studying. So any developments on that side of things, anything that's really being looked into from, what the choices we make, we are what we eat, the sleep cycles, anything on that we can share with our population who, are very keen on this area?
In ALS, so there's 2 big prevention initiatives going on. One is to follow people at high risk for the illness who carry the gene, and where we know that not everybody will get the illness, and study these lifestyle things, as well as fluid and other genetic markers, or what's different about the biology of people who get the illness and who don't, and also like age of onset. And I'd say that the biggest thing that's coming out of that is actually from these studies where they look at at the genetic background of people, and finding, for example, that people who are kind of healthier in terms of their heart. In particular, there's some data that people who actually take statins, which are to lower cholesterol, are at a much lower risk for ALS. We don't know yet about the sleep and the exercise, but I think that everything points towards better brain health for people who sleep well and who exercise and who eat, who keep their weight down.
But also in Alzheimer's, right? Like highly processed food, there's been studies now around highly processed food being a factor to be considerate about, sugars particularly, and then supplements. I'm interested in your thoughts on supplements, even like I think I read on Alzheimer's Association's website about the daily multivitamin could be something that is helpful. What are your thoughts around that?
Yeah, so the data on any particular intervention are, stronger or weaker and so forth. But I think the general theme that you're speaking of and that Merritt addressed, which is this, I think a new appreciation of what in retrospect should have been obvious, that your brain is as healthy as the rest of your body is. That if there is inflammation, if there's stress, if there's any number of things that are going on, that affects your brain too. And it's obvious from introspection, right? If you don't get a good night's sleep, are you fuzzy in the morning? Well, I am, right? If you don't eat well, if you're not exercising regularly, not only myself, but most of my patients tell me they just feel better. They think more clearly. And all of those things, I think, add up. For any individual, it might be like what kind of exercise fits right for your body. I think there's a lot of personalization that has to happen. But I think the broad picture of a healthy body and exercise is an especially important component of that. Leads to better brain health. The other piece which Merritt mentioned, but which I want to sort of double down and reemphasize, is that cardiovascular risk factors that we've always sort of gone, oh, well, that's something else. It really looks like they impact brain health. And so blood pressure control, better blood pressure control than historically had been the case, especially in the elderly population. And other cardiovascular issues, including things like good diabetes control. And there had been a sort of a sense in medicine, oh, they're 70, they're, getting old. Let's not fuss with, again, their blood pressure under super tight control. Let's let their sugars run a little high, whatever. That's really being thrown out the window. It's they need even better control when they're elderly. And there, the data are very clear from at least two different big international trials that paying attention to blood pressure, paying attention to exercise, and paying attention to glucose control makes a difference over the person's lifetime in how healthy their brain is.
So, last 2 minutes, I'm curious. What's next? It seems like there's a lot of attention and focus around gene therapy, and that's super promising and exciting for everybody. And also, I guess, part B to that question, what's your involvement? Why is the money that Run to Revive is sending to Mass Gen the best place to send our money? Because you alluded to very humbly your involvement in what's happened over the last year. But I guess to Tom's point and the way he started this, brag a little more. We want to hear why, our contributions and our supporters' contributions are going to the right place.
So saying ALS, the initial breakthrough of even understanding this illness came from Dr. Robert Brown at Mass General when he discovered the first gene that causes the illness. And here we are now with the gene therapy that fixes that particular gene, and a lot, if not most, of that work happened at Mass General Hospital. Also, we created a collaborative global trial group to try to bring treatments to people where they live and to accelerate treatments, really fostering this idea that in this illness you have to collaborate and work together. And Mass General really is leading that effort, and has, before big data and AI were popular, we brought that idea to every data in our trial needed to be shared openly, samples openly, because we couldn't waste any time. And that culture is now really global, and really proud that our investigators here were really the leaders in that.
You've heard from both of us this sense of urgency, and I think we deeply believe that similarly in Alzheimer's disease, the fundamental genes that lead to autosomal dominant Alzheimer's were all discovered here at Mass General, and we've been taking the lead in gene therapy and in other approaches to help. But it's that sense of urgency that we have, and the leadership that we can then give on behalf of our patients to try to make a difference. And that's part of the water here.
Fantastic. Well, we certainly don't want to hold you back from doing your fantastic work anymore today. So thank you so much. It's always an honor to speak to two, real experts in the field. And thank you on behalf of Rob, myself, and the rest of Run Revive for your dedicated work into these two areas. You provide us with hope and the motivation to keep going. We'll proudly announce that our goal is to try and double the impact again this year. We're still working on that plan, but it's definitely going to the right place. So we really could not appreciate you guys more, and we love our association with the MGH Neurology Group. So thank you, you guys.
Thank you so much.
Yeah, thank you, Tom and Rob, and to all your the runners and supporters. Thank you, Alexandra.
Of course, you guys. Thank you so much. Rob and Tom, if you guys need anything else or have additional questions, you can just send them to me, and we can get them typed up and answered, for your crowd too.
Perfect.
Thanks.
We appreciate you all. Take care. Have a great day.
Thank you, guys. Have a good day.
Bye.
Bye.
Bye.